Okay, we're going to start. So it's a great pleasure to introduce Cheryl Cashin. Cheryl is one of the world's experts on provider payment mechanisms. I'm sure that many of you will recognize her. She's worked in many of your countries. She has lots of on-the-ground experience. She works for R4D, and it's a great pleasure to have her with us this morning. She's going to present to us about regulation, and after her presentation, we'll do the case study. Okay, so I hope that if you have not read the case study at the break, you'll read the case study on counterfeit medicines in Nigeria. We're going to talk about solving difficult problems. Okay, are there any questions? Any concerns that people have? Let me remind you, 2 more days, today and tomorrow, and then we're completed. Okay? Any questions? We'll have coffee at the break, Nadim?
Yes, there will be
Coffee at the break? Okay? I hope you all had a good weekend. Did you have a good weekend?
Yeah.
Did you get to see Washington? Was the weather nice? The weather was beautiful. Okay.
Thank you, Michael. Good morning, everyone. Good morning. So you're here for a big week in the United States. You'll get to see a little bit of a spectacle tomorrow when we have our elections. I want to just say hello and just ask a question, and I'd like you to answer honestly. How many of you were excited when you saw the topic of the session this morning was regulation? Not many. Thank you for being honest. Regulation has a bad reputation sometimes, right? Sometimes we think of it as this static thing, these rules that are out there. Sometimes they don't make sense. A lot of times they don't make sense. Maybe they're not enforced. And so let's try to use the next hour and 10 minutes or so to change that. But what do we mean? So I often think back to 1994 when I landed in Kazakhstan for the first time after the Soviet Union broke up. And I got off the plane, and everywhere were signs. No smoking, no smoking, no smoking. Under almost every sign, there was someone leaning against the wall, smoking. So that, to me, was a regulation that was probably not really working. And it turned out to be pretty much my experience in those early days. The Soviet Union was one of the most bureaucratic and regulated systems, but they weren't working. I think some of you are nodding. I think some of you are from the aftermath of that system. So fast forward 7 years, and I'm working in Germany, living in Germany, and there were a lot of regulations, and people followed them. And these regulations were followed, and things were orderly, and sometimes there were rules that were made by the people themselves. The government didn't even make the rules. The rules about how you can behave when you're living in an apartment building with many people. And I found myself in a lot of trouble because I was cooking something really smelly, and there's a rule against that, an unspoken rule. So what was the difference between these two situations, do you think? Enforcement. Okay, that's the obvious one, right? What else? Culture.
Also the approach maybe and how they did the regulations, how they implemented them,
Mm-hmm.
have a huge part in having people actually do it.
Right, that people believe that these are good rules. What else? Punishment, the consequences. Any others? Public participation, good one. So I think all of these ideas that you're sharing, to me, crystallize into two things. One is legitimacy. Did the rules have legitimacy in society? Do people believe that these rules should exist and should be followed? And if they don't, that the situation will be worse? And the second, for me, is opportunity cost. What is the cost to me of following the regulation versus not following the regulation. So that links to enforcement. It's also incentives. It's also culture, because cost isn't only financial. Is there a social cost to me of not following the regulation? There certainly was to me in Germany when I cooked that smelly garlic. There was a big social cost in my apartment building. So what are the costs relative to the benefits of following the regulation, the cost of following the regulation versus the cost of not following? So I want to keep those things in mind as we go along today and look at regulation in practice, what's happening, and when it can be more effective. So how we're going to divide up the morning, these colors are terrible, I apologize for that. First, just what is regulation? Let's get a working definition of what we mean by regulation, and then why is it necessary in the health sector? Because if we think regulation is kind of a burden and red tape and maybe slows things down, there must be a justification or we wouldn't have it. And then let's look at how it's actually playing out in practice in some of your countries and other countries. How is it actually working to achieve the objectives that we have for it? And I think I'm not going to be giving away too much of my story if I say it's not working very well. And now let's look ahead to what are countries doing to make regulation more effective? If we believe it's necessary, how do we make it more effective? And then I want to hear from all of you some stories of what has been working well and maybe not so well in regulation. So what is it and why do we need it for the health sector? So if you look back, how regulation is defined even, just how we define it, has evolved over years. If you look back to 1997, OECD, the Organization for Economic Cooperation and Development, they defined regulation as laws, orders, rules that are put in place by the government on enterprises, citizens, and sometimes the government itself. Rules, laws, order. Okay. Command and control, we call that, or the bureaucratic definition of regulation. And then a definition that was used in this course that our dear Mark Roberts came up with, and saying that this is actually, for health, it's coercive efforts by the state to alter behavior of the actors in the health system, all the actors. So this gets more at what we're trying to achieve through regulation. We're trying to make people do some things that they don't want to do, or not do things that they want to do. And so there's always going to be a little friction there, right? And more recently, if you look at definitions, they tend to be a little bit more holistic, as they say, a holistic view of regulation. It involves more actors, more participation, more incentives. So acknowledging more of the reality on the ground of what it takes to change behavior. So I think this evolution of definitions is very telling and is going to help us get to the story today. Any other definitions that you want, any other thoughts on regulation before we get to reality? Is this how you think about it? Anything that's missing? Okay. So why do we need regulation in the health sector? What are we trying to achieve? That's the most important thing, I think, with any policy. What is your objective? So we know we want to try to change behavior, get people to do things that they don't want to do, or not do things that they want to do. But we want them to change behavior in a way that achieves a few key objectives for the health sector. The number one is quality of care. We want to make sure that when people access health services or medicines, that they're at least safe and hopefully effective and of good quality. We want to make sure that financing is fair and that people are paying prices that are fair and that they can afford to pay. We want to make sure that the burden of financing is equitable. And I'm sure it came up in the other sessions that one of the ways we judge a health financing system is if people pay in based on their ability to pay and they receive based on their need. And accountability, that all of the actors in the system are accountable for doing what they're supposed to do. So if we keep this in mind, all of our regulations should be moving the system to achieve these objectives. And of course, these tie back to the control knobs and how the different control knobs are working towards bringing out the outcomes in the health system that we're trying to achieve. So in this way, we want to always also keep in mind that regulation is very much tied to the other control knobs, and we'll give some examples of that. So why do we need regulation in the health sector? Doctors and nurses and other providers, they enter the profession because they want to help people, right? So we should be able to just assume that their actions will be well-intended and that they'll want to do the right thing and always help people and be ethical. I think that's a very good assumption in general, of course. However, you can open up any newspaper in any country on any day and see abuses of that trust. And there are a lot of reasons for that. We're not going to try to understand all the reasons for that, but it happens. It happens a lot. And I found more examples even preparing for today. Every time this session comes along, there are new examples of abuses of the public trust in the health system. So this is fundamentally about human suffering and life and death. So there is a role for some sort of control and accountability of actions of the different actors. There needs to be a set of rules of the game. We need to know what to expect when we participate in the health system. Who is obligated for what on all sides? There needs to be some rules of the game that we all abide by. So what I hear in my country a lot is, well, the market can do this. If you leave it to the market, that will put pressure on the actors to behave in the right way. Otherwise, they'll lose business. That sounds right, right? If you go to the market and 3 times in a row you got spoiled meat, you're not going to go back to that market. So that's often the argument that we hear, let the market put these pressures on. But the problem is, does the market work well for health? So in a perfect world, if the market did work perfectly, you could go to the pharmacy and you would expect to get high-quality medicines that weren't counterfeit, that were appropriate, dispensed in the right way to solve your problem according to your prescription. And you'll pay the fair price, a fair market price. And if any of that doesn't happen, the pharmacy will go out of business because everyone would find a different pharmacy. So is that how health works? Is that how healthcare works, when you go out and seek it, that you can use your market forces to make sure that you get good quality at a fair price? Oh, I have a lot of obstacles here. Limiting my free flow. Oh, table mics. Okay, perfect. I didn't see one.
Patients don't know. There's an imbalanced knowledge situation.
Exactly. In fancy economic terms, we call that asymmetric information. That the seller has more information than the buyer about some things. About what will work, about what things cost, how much you actually need. And if you don't have perfect information, how can you make an informed choice and use your market power? How else does the market fail in health?
There's also usually a lack of suppliers. So some will just continuously go to the same pharmacy because they don't know where else to go.
Yeah, in healthcare, you have concentration of suppliers or few suppliers sometimes, especially the higher up you go in the system, there are few hospitals. So where I live on Eastern Long Island, it's way out, 2 hours past New York City. There's one hospital within an hour of where I live. So sometimes that hospital doesn't have great quality, I can tell you for sure, but there's no other choice. So we can't use our market power to put pressure on that hospital to up its game. So concentration of suppliers limits the market power of the buyers. Can you say something?
Another thing is purchasing power. How much money does the buyer have to purchase good quality?
So an individual, when you go by yourself, you're not going to be able to influence the price or the quality. However, if someone purchases services on your behalf, which I'm sure you talked about last week, then that purchaser has more power and can dictate more of the terms. Next. to counterbalance the monopoly power of the suppliers. How else does the market fail? So when I go into the grocery store, I know that I want to buy rice. I know what good rice looks like. I know I can judge if it's good quality. I can judge if it's the right price because I know how much rice is at the other store. Is that true for health? No. No, we don't know. We don't know. The providers often don't know their costs, and the buyers don't know the fair price. So there are a lot of ways. And I think one of the most important ones that probably also came up in your discussion last week is what we call the agency problem. When you go to see a doctor, that doctor is making suggestions to you about what to buy. And that doctor has more knowledge, asymmetric information, and is acting on your behalf to make some of your purchasing decisions for you. And sometimes that provider might have a financial interest in that decision. So might not be making the suggestion that's best for you. So for all of these reasons, we just can't leave it up to the market to make sure that everyone behaves in the way they're supposed to behave, and that we have fair and honest outcomes. But that's not the only reason. Even when markets function well, the market for Coca-Cola, many buyers and sellers, you know exactly what you're getting when you buy a can of Coke. All of the conditions of perfect market applies. There's going to be a price that all the sellers have to gravitate toward. If they don't, then they'll lose business. Even in that rare situation where you have a quote-unquote perfectly functioning market, you still need rules of the game. You still need some rules of the game. There's still regulations even in perfectly functioning markets. And we never expect the market to distribute goods and services fairly, equitably. That's not the role of the market. It's whoever has the willingness and ability to pay gets the goods. Is that how we want our healthcare distributed? Of course not. So the market will never solve the equity problem. So we have a market failure and a public interest justification for regulation. So if you ever get in any arguments with Americans who are on the conservative side trying to go back to privatizing our health system, you can tell them that, in fact, the market is not going to get us where we need to go. And I have that conversation almost daily. So all this talk about markets, we think we're talking mainly about private providers, right? Is that true? Do you think public providers also should be regulated? Why? Why? They're serving the public. They're paid by government money. Do we have the same problems? Why? Tell me why.
Dual practice, I mean, they might be working by day as public, by night as private.
Others? How big of a problem is dual practice in your countries? Yeah. Are there regulations against it? No. Doesn't work. So what you said is absolutely true. There is increasingly a blurred line between public and private. There are private wards in public hospitals. There are publicly paid doctors earning money in their private practice through dual practice. There are all kinds of blurring. And so the same issues that you see in the private sector are equally visible in the public sector. And even when there isn't a blurring of the line, there is still problems with public providers meeting all of their social contract on their own. And it can be really a problem, this pushing public providers to behave more like private providers, but then not regulating them. It's almost a worst case scenario, and this is popping up in some countries. In Vietnam, where I've worked quite a bit. Do we have anyone here from Vietnam? Yes. Yeah, so there was a policy they called the hospital autonomy policy that made hospitals responsible for generating almost all of their own revenue, except salaries. And so it forced them to start charging patients There was some regulation about the fees that they could charge, but it wasn't well developed because it's the public sector. And all of a sudden, you see hospitals trying to get as many patients as possible, charging as much as possible, so really encouraging higher cost services, keeping them as long as possible, and in order to cover their budgets. So these are not, terrible motives. They're trying to survive and stay available and accessible to the public. But the incentives they have are to behave like an unregulated private hospital. And so hospital overcrowding became a crisis at some point in Vietnam because of this policy, because of the public providers being forced to behave like private providers and with very little regulation around that. So I know the title of this session was talking about private providers and regulation, but it's really, we need to look at this issue holistically. It's one sector, and there's very little delineation that we can really say anymore between public and private, and public providers also need to have a regulatory framework that they operate under. So countries are increasingly looking at a holistic way of regulating across public and private for a lot of reasons, which we'll get to create fairness and also recognize that there's very little difference in some cases between public and private. Yes?
But sometimes the regulation, even if the regulation works, government, in terms of government hospitals trying to be like private, but charging fees, the aim of government is to provide services, but at a very low cost. More often than not, like the Vietnamese case, you now find out that probably they are charging and they're providing excellent services. Then what is the essence of regulation? Which means if we are allowed to charge the government facilities, such as like the private facilities, you could provide the same services. Then what is the line between? Yeah, sometimes even better, actually. Even better.
So in this case, I think in Vietnam, it's not saying that the quality is bad. What's happening in this case is because of the strong incentive of hospitals to pull patients, it's pulling patients who could be treated properly at the primary care level at a lower out-of-pocket cost. But instead, they're being encouraged to go to the hospital at the provincial level, pay a lot more for services, maybe of excellent quality, your point is well taken, but with a lot of out-of-pocket burden. And so even though they have almost universal population coverage with the social health insurance system, out-of-pocket payments are still a very large share, and this is part of the problem. So it's more of a financial burden in this case, although the quality might be good. I don't have any information about that. Any other comments on this? Okay, so where we are so far. We've justified, we definitely need regulation in the health sector. There are a lot of wonderful altruistic providers out there, but there are definitely incentives in the system that drive both public and private providers towards maybe self-interested behavior. Yes, please.
Sorry, one more comment on this.
Yes.
So the point here is that we're asking them to act like private, but we're not regulating them. I also have one more issue here. We're not giving them incentives.
Yes.
Sometimes we are asking public providers to deliver in the same efficient way, with the same creativity and the same outputs as private, but we're not giving them the resources.
Yep.
We're also not giving them the incentives.
Mm-hmm.
We're not rewarding them for this behavior as would the private sector. So that's something we all fail in the public sector, I think.
Well, that's a really excellent point, and it might come up later in another example of overregulation. But in a case in Indonesia, which we'll talk about, that primary care providers who are public have been given more authority to act more in a private way. They're paid for services rather than only by budget. But the regulations are still so strict, they don't have the autonomy to even move around and respond. So their hands are tied. So we're asking them to behave more like private, but not giving them that flexibility that private providers have. So, excellent point. Any other thoughts on this? All right, well, let's see what's happening in reality. So we know that we need to have good regulation. We need to know that it's not just about a private sector issue. It's public and private. And we know what we're trying to achieve through regulation. So what's going on out there? Let's start looking at the reality. First, what is regulated? I think we're all very familiar with this, long list of things. This is just on the supply side. all these different regulations about what medicines are allowed in the market, which providers can deliver which services, quality standards, all of that. So there's a lot of regulation, mainly directed toward ensuring quality and safety of healthcare goods and services. A lot of regulations around that, and that's what we're mostly often familiar with in health regulation. There also is a whole lot of regulation around the financing in terms of what fees can be charged, how much they can be charged. Are you allowed to charge patients extra outside of what you're paid by a public purchaser? Are there any other restrictions around how you can be paid? So all of these are on the financing side, and also on the insurance side. There's a lot of regulation around insurance. We don't have time to talk in detail about this today, but there are a lot of market failures in health insurance, both public and private, that require regulation. And a whole host of other things. So regulating information. What information can be put out there about health? I was so shocked. So after my years living outside of the United States, I came back home, I think it was 2002, turned on the television, and every 10 minutes was an ad for a pharmaceutical, a drug, which was not allowed in the past. There was a regulation. You were not allowed to advertise directly to consumers about medicines. All of a sudden, this changed, and the television was flooded with advertisements about medicines. Is that a good thing or a bad thing? We could debate a lot, but that regulation changed. How you label products. This is something that was very interesting for me in Chile. Has anyone from Chile or has been there? If you go to a shop and buy a candy bar, it has stop signs on it with the calories and the fat, and the labeling now of food products is regulated. You have to let people know when there's an unhealthy product. That would be very difficult to pass in this country. So, impossible, I would say. Yes, I have to agree. They've made some progress on the labeling, but these are all regulations that are related to health and safety. So I want to stop here and just ask your observations. So I just shared very quickly the kinds of regulations in health service delivery, in pharmaceuticals, in financing, in other information and other aspects of the health system. What do you notice? Let's see how observant you are.
Overall, from what you said, the regulations generally tend to protect the consumer or the public, but not regulating the government itself.
Okay, very interesting observation. Anything else that you see? What about the kinds of instruments? We talk about regulatory instruments. What do you use to try to change the behavior? Well, I've showed you 3 pages of rules. The rules on the book. We call this the command and control, the bureaucratic style. This is the rule. You follow it, and if you're caught not following it, then there's a penalty. Okay. So we call this command and control, bureaucratic, or traditional, in my view. And it's very optimistic, don't you think? It's a bit optimistic. Yes.
I also observe that the consumers are not being regulated here.
The consumers are not being regulated. So what would be some regulations that consumers should face?
There should be a penalty for anyone who goes to procure health from illegally, or maybe from a non-registered provider.
Mm-hmm. So there are sometimes regulations that regulate how you can flow through the system, but it's often tied to payment. So I can bypass these regulations, but I'll have to then pay out of pocket. But there aren't usually strict regulations about what care you can seek. So yeah, also a good observation. So, yes.
I just want to share something that I'm not sure is true in other countries, but I think to a certain extent it is in Lebanon. So our private sector, especially in health, is booming. It's a very good sector. They actually provide good quality care. We have some of the best hospitals. We have medical tourism from Iraq, from Syria. People come when there's something serious. But the issue is they are so strong that the traditional command and control from the government wouldn't really work. So you have the minister, like some of the tools we use, the minister sends a memo or a decision to all private hospitals. They don't necessarily abide, and like you said, it would be optimistic because we don't have the capacity to always check. And even if we find something failing, we don't always have the capacity to enforce the consequences. There's that issue. So our Director General has a more collaborative approach. So for example, I remember a few years back, he wanted to bring everyone to the table and agree on a code of ethics for advertisements of drugs. But this approach is also very hard because it's so hard to bring everyone to the table with different interests. And when you as a government do not have the authority or the enforcement power to say, this is how I want it, this is how it's gonna be, it takes time when you want all these people to agree on a common vision. So I see the attraction of participatory approaches and collaborative approaches, but it's also not very easy. So you have to be so till now, the code of ethics that the Director General started working on maybe a few years back, till now it's not enforced in Lebanon because not everyone agreed on it. So
can you keep that example for the next part of this session, because when we get to those other approaches and the potential successes, but also the deep challenges with other approaches. But I think no one is saying that these aren't necessary, that you have to have these rules. This is necessary. The question is it enough? Right? And so what can we do to make sure? So let's see, any other comments before we look at some of the experience? So there's a lot of regulation. There is no doubt that all of those boxes I showed was the tip of the iceberg. Under each of those are many, many, many regulations and other rules that different countries put in place. So how does all this work together? And I just say there's a simple answer, that there's abundant evidence that the regulation alone, these rules alone, are not enough. And how do we know that? We know that because the things we're trying to achieve are not being achieved. Remember at the beginning, we're trying to achieve good quality healthcare goods and services. We're trying to achieve fair financing and limit out-of-pocket impoverishing payments. We're trying to enforce accountability. And we just have evidence over and over again that this is failing. And so that's how I can say I think these regulations alone are not enough, because we're not achieving the objectives that we're trying to achieve. And just in preparing for today, all over the newspapers, in a few countries, not just one country, the latest horrible thing, hospital patients being held hostage for cash. So this is not, and this is several countries happening right now, it's making the news. So we're failing, that this is not something that is really legal in most countries, but it's happening. So the regulations against holding people in the hospital until they pay their bills are not working. So let's dig a little deeper into why. I think you've all raised some of the reasons why this simple putting a rule there and putting some penalty if you're caught not following it in place is not likely to be enough. So we want to break apart the reasons. Okay. So these issues might be failing because the regulations aren't necessarily good policies or priorities in themselves. And that goes back to social legitimacy. Are these legitimate actions that society agrees that we want everyone to follow? And that can fail. And this can fail in a lot of ways. Getting the priorities and the goals of the policies, the regulatory policies wrong can fail because the government just doesn't understand or makes decisions without understanding what is legitimate and what the priorities are of the society. Or the process could get captured by people who have financial interests in having the regulations support their own objectives. So an example of that is pharmaceutical registration, that you would think the goal should be to make sure that unsafe products are off the market and effective products are on the market. However, pharmaceutical registration is really susceptible to capture because pharmaceutical companies have a different set of priorities and an agenda and have a lot more financial power. You can have the right goals, but then of course it can fail in design. If you design the policy in a way that just makes it not very feasible, you can design the policy in a way that it's costly to people to comply. It's more costly to them to comply than the penalty if they don't. And we see that a lot of times with the pharmaceutical registration regulations. They're so burdensome. Again, going back to Kazakhstan, one of my colleagues was working for a private pharmaceutical company and came back and showed me the books of procedures they had to follow to register. And then found out later that they couldn't register some of their products because they were maybe captured by others with different trademarking laws and regulations. So the burden was so high, they just often just went around it. They wanted to comply, but it was just too hard. And then, of course, our favorite, implementation. You can have a great policy that has the right objectives, that society has consensus around, very carefully, well-designed, but then it fails in implementation. So your pharmaceutical registration regulations might be appropriate, they might be streamlined, but then they're not enforced because you don't have the human capacity to enforce it, or for other reasons. So we have to go back to all three of these ways that the policies can fail, and then at the end of the day, we see the regulations not achieving what they're meant to achieve. So let's look at a few examples. Regulatory capture, it's very, very serious, in fact, especially on the pharmaceutical side of health services and products because of just the huge amount of money. Out-of-pocket spending for pharmaceuticals is often more than 50% of total out-of-pocket spending. The money is just huge. It's just out there to possibly be up for capture. So here's an example from India that had the original goal of their policy about consent to participate in drug trials. The original goal was to protect the people, the citizens of the country, from being involved in drug trials that could be dangerous or possibly unethical. And the global pharmaceutical companies were finding these regulations around human participation in clinical trials were getting tighter and tighter around the world, so they didn't have enough people to do their trials, and they were so kind of got the ear of the government and said, we really would like to have opportunity to do more of our trials. In India, the regulations were relaxed. The goal was switched from serving only the public interest to also serving the interest of the pharmaceutical companies. And there was a lot of backlash in India, a lot of backlash. This actually turned out to be quite a negative policy shift. Okay. So then what about problems of design? So in Tanzania, there are a lot of regulations about how you can dispense medicines. And these regulations make perfect sense about the qualifications of the dispenser, about the conditions of the pharmacy, that you can't have an informal drug shop that don't have certain infrastructure in place, certain other regulations, here are a few. And there's a lot of consensus that these make sense, so they have social legitimacy. But the design of the policy sets standards that it turns out that are very difficult to meet on the ground. So even though they're aspirational, they make a lot of sense. No one can argue with them that you shouldn't be dispensing single tablets in fact, on the ground, the drug suppliers can't meet them. And so there was a survey here that showed the number of drug shops with infringements in all of these regulations. Out of 30, almost all of them had some infringements. Like they just couldn't meet these regulations. And so they're not based in reality. So the design of the policy was not going to allow it to be effective. And then, of course, the issue of enforcement. So in the Philippines, there is a financing regulation that does not allow hospitals to bill patients extra beyond what the hospitals are paid from the health insurance agency, PhilHealth, if the patient is identified as indigent and covered through the indigent program. And so this is called no balance billing policy. Sorry? So PhilHealth is their national health insurance agency, pays for the service. And if you're indigent and you're covered in that way, the hospital is not allowed to charge you any more than what the insurance agency pays on your behalf. Well, yes, that which is probably often the case, which is probably a topic that you took up last week in the purchasing session. Yeah. Yes, but so this is a really important example, and you're absolutely right, of how the control knobs need to fit together. Because if you only regulate and you impose a regulation that is not tied to other policies, you can do more harm than good. If you limit what can be paid without understanding how purchasing can be used to improve efficiency gains or to ensure quality and to put all of the policies together, one regulation in isolation could do more harm than good. So you're absolutely right. No, that's a very good point. So in this case, the policy was announced in 2012 to go into effect in 2013, that you're not allowed to bill patients extra beyond what PhilHealth pays you if they're indigent. And so that is the green bar. And then they looked, so the number of hospitals complying with the regulation at the baseline, and then the number of hospitals complying, percent of them complying over time. So in 2014. These are public hospitals. The compliance was under 60% at its peak. These are public hospitals. So the regulation is very difficult to enforce even among their own hospitals. Okay. Probably part of the reason that you mentioned is that maybe it wasn't realistic, that there's no way they could cover their costs and deliver good quality care without bringing in extra funds. A lot of reasons that are at play. But very difficult to enforce. Yes?
Just go back to the previous graph. I know that the compliance is low, but it's only 3 years, and there is quite a significant increase. Do you have any insight to share why it is the case?
Well, because, I mean, it definitely, once the rule was implemented, many hospitals felt they had to follow it, and many did. So I think, of course, you expect to see the compliance increase, but it didn't increase so much. And in fact, if you see some of the higher level hospitals, the yellow bar is actually lower than the green bar. So after the policy was introduced, compliance was even lower. So they were trying to, I think, get the revenue they needed before they felt that the enforcement might pick up. Even so, it looks like, so 40% in total after the baseline, it's still very low for a public hospital, I think.
But it's only like 1 or 2 years, so I see it's quite a kind of a significant shift.
Yeah.
Depending on how you see it.
That's a very fair point. So the other problem, so having regulations that don't have the right goal or that are not properly designed or not properly implemented, that creates problems that sometimes make the regulations do more harm than good. And that can happen in a few ways. It can happen by restricting access to necessary services, or by reducing what would be considered productive behavior. So in the case of Tanzania, the drug shop case, if every single one of those drug sellers that was not complying with the regulations was penalized or shut down, or then they decided that actually that would hurt the population because they would have no access at all to the medicines. So they made the decision that it was actually better to back off on the regulations, not enforce them so strictly, rather than take away access to the drugs to people. In that case, the enforcing the regulations would have done more harm than good. And there are some other examples of that. In Pakistan, there was a clear case of withdrawing one of the medicines for diarrhea. They deregistered it for children. And so what they did, they shifted to an adult formula, which was dangerous. So by enforcing this regulation, it actually made things worse. And then going back to the example of Indonesia, how regulations can limit productive behavior. So the primary care providers in Indonesia have revenue that they get from the national health insurance system. But there are 11 regulations that specify how they can use that revenue to make sure that there's no fraud, no misuse of funds, which of course we don't want to see, but 11 regulations that overlap, that contradict each other. They're so confusing. The providers say, I'm just not going to spend that money at all. It's too risky if I spend it wrong, which there's a good chance I might. I don't understand these regulations. They don't spend it. And the money goes back to the Treasury and is not used in the health system. So it's a case of really good intentions, wanting to limit fraud and abuse and misuse of funds, but going too far can actually limit productive behavior and have a negative impact on the objectives that you're trying to achieve. Any other examples of overregulation? Yes.
I want to give an example of the overregulation in our bank project, in the Emergency Primary Healthcare Restoration Project. So the idea was to give primary care professionals, primary care centers, that we have a 25-year, they are a private sector NGOs, and we have a 25-year relationship with them where they were giving services and they were not getting any money from the government. They were just getting in-kind contributions. So the idea was bringing in the money from the World Bank grant will give them money in return of delivering a certain package of services to poor. So the bank is so obsessed with knowing where every dollar is spent, etc., which in turn makes our procurement and finance people super obsessed, where they want to regulate every dollar, although our idea was to give this money in a way that is called capitation. So in capitation, you don't know where every dollar is spent, but they still want to know where every dollar is spent. And they put regulations and they go down to the primary care centers and they go through their books, which we don't always have the right to. And they want to see that they spent the $60 that we spent on capitation. At some point, they wanted to see receipts against the $60 capitated fee. And we said, this is impossible. If you do that, it will make us look bad because the diabetic patient is going to cost them $300 and you're giving them $60. So yeah, this whole thing of regulating to make sure there's no fraud, sometimes the finance people take it too far.
That the consequences of that are actually worse than the consequences of fraud in some cases.
And in our case, the centers, they were very frustrated. They thought we have lack of trust in them after a 25-year relationship. And also, they started saying, well, you know what? The money you're giving us is not enough, which is true.
Yes, which is true.
Yeah.
Good. Okay, so we have all of these reasons that we know why we're not achieving the objectives that we have set out with regulation. That there are gaps, fragmentation, overlap, regulatory capture is possible, the capacity to actually enforce is low, and there's sometimes just government failure, just not carrying out its duties. All of this, I think we can trace back in some ways to legitimacy and opportunity costs. Right? And so let's see how that is translating into some new approaches. Yes.
Sorry, please. Now, why regulations fail in some of these countries? Now, more often than not, like now, insurance is emerging in many low and middle income countries. Insurance and many health financing policies are emerging in many low and middle income countries. And more often than not, the regulations or the design of the program is actually influenced by international partners, which, like you put here, one of the reasons is capacity. That's a place where you put capacity. Yes, and then lack of realistic to the local realities. Now, more often than not, you bring what is working in another country, in Vietnam, and bringing it
Yes.
into another country with
Can you get
complete.
closer to the mic, please? They're not able to hear you.
Okay, okay.
You're
I said,
making an important point.
yes, the
Cameron?
regulation said unrealistic standards given local, without taking into consideration local realities. Our international partners, including the World Bank, I'm sorry to say, will use their experience probably in even say Tanzania, now bring it to Kenya, hoping that because they are contiguous countries, it will work. More often than not, it does not. And after 5 years of implementation or 3 years of implementation, you now find out it's not made progress. Then the blame is now given to government failure, corruption in the country, low political or institutional will. But the reality is that you set standards that are unrealistic to the local needs. What do you think about that?
Thank you. I completely agree. I think there are standards that aren't legitimate according to local context and maybe not realistic according to local realities. I think that comes up a lot, a lot, a lot. So what do we do? What do we do? Let's talk about what some countries are doing. So I think there, at least over the last 10 years, there's a recognition that these approaches alone are not sufficient, and we can keep turning a blind eye and keep just saying it's just a matter of enforcement, just a matter of enforcement. That's not getting at the root of the issue. And I think that you summed it up beautifully, the root of the issue. And so looking realistically, how do you get legitimate approaches to regulation with reality-based standards and looking at other ways to encourage the behavior, to bring together the forces of incentives, of social pressure, of other things that require that people participate, and to get at regulatory frameworks and rules that have that legitimacy, that people buy into, that they will then find it more valuable to comply with than to not comply with, and to make all of those forces work together to push the behavior in the direction that we want it to go. That simply putting rules down and quote unquote enforcing them is just not going to be enough in these situations, especially when those rules are completely off base. So these are the trends that if you look across what countries are doing and what some people who've been thinking about this for a lot longer than I have are writing about, is there's some trends in the way that regulations, regulatory frameworks and environments are being developed. And the first is moving away from an idea of coercive to collaborative. That recognizing that people have to be part of the conversation if regulations are going to be legitimate and accepted in society. That there needs to be a little bit less of a bureaucratic approach and a more flexible, like in Tanzania, when they saw that in fact these standards are great on paper, but they're not great in reality, being a little more flexible in how you enforce them, saying, okay, we have this aspiration, but we're going to get there over time and with steps. We can't just impose this tomorrow, or we will have no pharmacies available for people. And moving away from only command and control to bringing incentives, and not just through purchasing and contracting, but incentives, making it worth people's while to comply. That the opportunity cost of complying is lower than the cost of not complying. And rather than top down, coming from the outside, maybe not even the top, but from the outside in, and having more reality-based standards and approaches. So these are the trends that we're seeing, and I'm just going to maybe dig into a couple, but I want to hear your experience. It sounds like we have some good experience in the room. So more market-based approaches, and this links back to your session on strategic purchasing. If we're moving towards universal health coverage, and that means that we're pooling more funds and fewer purchasers have more purchasing power to buy services on behalf of the population, that purchasing power becomes a way to regulate. That now we can say you have to comply with these standards if you want a contract. So if you don't, that's fine, but then you're not going to be in the game. And so using the power, all of these levers that we're putting in place through universal health coverage to help move along and create the incentives for the regulations that we want providers and others in the system, including consumers, to follow. So here's just a quick small example in China that the government was trying to regulate private providers in China with very little success. And then they started to, in some of the schemes in one province, at least this example, there are others, to try to regulate through the contract. And by contracting with both public and private providers on the same terms, a level playing field, with the same rules, the same regulations in the contract. And what they found was that, first of all, the fees. They were having a hard time regulating the fees that private providers were charging patients. When they're contracted, they were limited. And if you want to keep your contract with the government, you can't charge excess fees. Their performance score, those under contract, is on the left. Their performance score was 83.8. Private providers who were not under contract had a much lower score. So they were able to have an impact, some pressure on quality that was stronger than just regulating the quality. And these providers were more productive. They were seeing more patients. And I think we see this in a lot of other examples. One example in Taiwan, there was a lot of problem enforcing regulations around TB notification. When a provider got a case of TB, they're supposed to notify the public health authorities so that the disease could be controlled. And the private providers just weren't. And so when the contract was amended, if you want to actually get paid by the government insurance agency to treat TB patients, you're not going to get paid if you don't notify the case to public health authorities. Notification rates went up 47%. Same regulation. The regulation didn't change. But the contracting mechanism added a financial incentive. So the other piece of this, so incentives is one piece, and the other piece is the process, the collaborative process. And this gets tricky, and I really like your example about how difficult it is actually to facilitate a collaborative process, so we want to get back to that. But this idea that you are setting the rules of the game with more involvement of those who are being regulated, and other stakeholders, including civil society and others who can put pressure on the situation, that you are working together to determine standards that are grounded in reality. So you are listening and understanding what that reality is, and then bringing that into the setting of standards, even if your aspiration is something much more rigorous. That you're bringing in incentives, not coercion alone, but real incentives. And we're seeing, in some cases, some increased role for self-regulation. So these are just some of the elements of what we're seeing. I'm going to share an example, and I want to hear from all of you if you have seen any other examples. So this is an example from an experience that I had in Ghana. And this is a combination, in fact, of the market-based incentives and collaborative regulation. So in Ghana's national health insurance system, primary care providers, at this time, this is no longer the policy, but primary care providers were paid by capitation, so a fixed payment per month to deliver a package of services for their enrolled population. So they have the incentive for good quality because they need to attract more patients. There were also some standards that they had to meet in order to be contracted by the government. You had to meet certain capacity standards to prove that you could deliver the package, the whole package. That part was set bureaucratically by the National Health Insurance Authority. So here was the package, and here were the standards that providers had to meet. This was set bureaucratically, those standards, and that was what a small group of policymakers thought was needed in order to deliver this package. So they found a lot of problems with capitation, a lot of complaints that we would go to our provider and we're not getting the services that we're supposed to get. So they did a survey. And they surveyed all providers, so from the lowest to the highest in the system. The yellow bar, the yellow part of the bar, are the providers who were able to meet the standards. Hardly any. And those standards were quite basic, but they weren't the reality. They weren't based in reality. So if the National Health Insurance Authority enforced their standards, there would be almost no access. And here's a map that shows that there would be huge pockets of the country where there was no access at all if all the primary care providers were excluded who couldn't meet these standards. So what did they do? They decided to take a collaborative approach. And they invited everyone in and discuss, okay, so what are the issues? You're not meeting these standards, why? And it turned out that it wasn't just because the providers were not, deciding to comply. They had issues with maldistribution of human resources. That was not at all the decision of the providers. There were all kinds. So they decided together, yes, these standards we think are the bare minimum, but we're not there today. How can we get there? And they worked on a plan that involved shared responsibility. So the government had to do something about the maldistribution of human resources. The providers had to do some investment to upgrade. They had to make sure at least their opening hours complied with the regulations, the things that they could do. And together tried to work on closing these gaps, not in a bureaucratic way, not in a command and control way, but in a participatory, reality-based way. So I think that these are some examples, some promising examples. We have other examples from Kenya where a group was brought together, providers and partners and the government, to develop the checklist for facility inspections together, but it required a facilitator. And that goes back to your point that these solutions are not also magic bullets, that they require a lot of other capacity that might be even more difficult to generate. But just want to take a couple of minutes and hear any examples from you, or maybe take a couple minutes at your table just to talk about any examples that you've seen in your countries of a slightly different, more flexible approach to regulation, and how is it working? Just take 2 minutes just to talk, because I want to hear some good examples. So do you have any good examples to share? Some new approaches, maybe some of the successes and challenges with those. What were some good ideas that came up at your tables? I heard a lot of discussion. Did anyone hear anything particularly promising or interesting? Any good examples at this table? No? Why not, do you think? Is your mic?
Lots of our regulation and law who was built up from in the Ministry of Health were opposed by the other laws in other ministries, and this was tackled by each other. And still it's very difficult to implement them and enforce them. Actually, they're not realistic.
So you have a number of issues there. So the contradictory laws and regulations across ministries is a challenge we find in many countries, and especially around health financing. And so a lot of times we see changes in health financing that the Ministry of Health is trying to introduce. They come in conflict with regulations in the Ministry of Finance or the Treasury or others. So it can be quite paralyzing. And then if you have standards that aren't reality-based, so it sounds like it's a bit stuck. So a bit stuck.
Our article is not short and not clear.
So
She means that the regulation, when they are written down, they are not so concise and precise, so they know what they meant. But also one big thing which our country nowadays is facing is also the capacity building. So we don't have enough and sufficient professional people who actually can deal and take the process from the beginning up to the end. especially we are trying to build the health insurance fund, and there are not so many professional people who actually understand the process and also can give you a professional proposal on how should be done. So more or less, they are all floating on the cloud and trying to see which one is more functional. Also, one of the big things for me, especially as I recently joined the healthcare sector, is most of the times actually the strategies and proposals which are done and proposed, they are not in correlation with the people who actually work on the ground. So they give standards and proposals and requirements which actually you cannot really implement them because you don't have sufficient people, you don't have enough capacity people also to follow up. Because if, for example, if you put a certain regulation at once, someone must follow it up. So there are not enough human resources.
So many challenges there, but one you highlighted that I have not highlighted, but is so important, and that is that how the regulations are drafted, how they're actually written, and that can cause many of the other problems that we're seeing, even if the policy itself is good, even if the standards are good, that if the regulation itself is drafted in a way that's confusing or contradictory, then it's kind of meaningless. Yes.
If we're speaking about the draft mechanism, I'm speaking on behalf of Indonesian. In Indonesia, I think the point is also need a leadership, transformational leadership. So like in Indonesia, our president give a mandate to the Minister of Justice or Minister of Law and Human Rights. So if to avoid the conflicted regulations that have been drafted, for example, from the Ministry of Health or Ministry of Finance, they have a harmonization or synchronizations between all the ministries. So it makes sure that no technical or more, because we have a leveling of the lot of leveling in the regulations. So it makes sure that Ministry of Health have been discussed together by all the ministries. So we have a collaborative also in the process. So the result is have been harmonized by along the all the sectors.
Thank you. That's an important example. So looking across the sectors and how to harmonize, I think that's a very important step, and to have the platform to do that and the leadership to do that. So it has to have the political will to make the ministries work together. So that's a great example, and I know a lot to harmonize in Indonesia for sure, with decentralization and the role of local government as well.
There's no one focal point that to harmonize. It could be a very difficult or a very confusing process. So that's why it's been implemented one ministry to collaborate a lot of ministries to result at one harmonized regulations. Otherwise, it could be a very time-consuming process.
Thank you. I think this came up in the Lebanon example. It certainly came up in Kenya and Ghana. The idea, if you're going to be more collaborative and try to agree across different stakeholders, who is the person responsible for facilitating that? What is the power and authority of that person or body to be the one collaborating and harmonizing and negotiating? Any other good examples?
First of all, I want to say that throughout your presentation, like light bulbs were flying off for me and Ala, because we have so many examples of mistakes, failures, successes. We have a lot of problems in Lebanon, a lot. But I can safely say that I think the primary healthcare sector has been a major success because it's based in collaboration. In fact, because the sector is based on NGOs that came up after the Civil War and after the whole infrastructure was completely devastated. And the government decided to collaborate with them in order to deliver services to the poor people and the vulnerable, because they had presence, they had the people's trust, they had the capacity, etc. And that's what we do. We give them in-kind contribution. Sometimes when we collaborate with a specific healthcare center, it's sometimes 3 or more partners within that same agreement. For example, we involve the municipality, the local NGO, sometimes the Ministry of Social Affairs. They're all listed as partners within that contract. We encourage this multi-sectoral collaboration at the local level, and we try to involve all these partners to ensure that we're getting funding from more than one source, we're all on the same page. Sometimes even the ministry would give them the facility, give them the building, and tell them, we don't have the capacity to manage it, you have the team, go and deliver services to those people, and it works. So the collaboration is definitely our approach. We have a lot of issues, it's not perfect, but I think that it is why we're successful at this point.
Thank you. It sounds like there's a lot to learn from that example, and I'd like to hear more about it and draw more from it. So that's really great to know that it can work and go in that direction, but it isn't easy. And I think that is also another key message here. Anything else to share from your tables? So I think you hit on the key things that I wanted to at least share in this particular part of the presentation. Yes?
In Albania, we are working very closely with doctors, and we create for the first time the contract between health insurance fund and the doctors based in some indicators, performance. And also with the private sector, we have others contract put in some criteria for the private hospitals, how they are providing their services to our patients. And also we have working in control, in audit clinic control based in protocol. Their private hospital provided their services to our customer because the patient is a customer. But my message for your presentation is the potential rule for collaboration and regulation in middle or lower countries with middle income, let's say financial. It's based on organization, planification, collaboration, and direction. But first of all, it's monitoring and evaluation, how we give a value to the people. Thank you.
Thank you. That's a very, very important message that we should be always keeping in the back of our mind. Is there some other comment from this table? So I think you all made the points that I was hoping to make with this. I think the first is that the command and control traditional bureaucratic regulation is necessary as a foundation. But to actually make it work and to bring it to life, there's probably a need for a lot more complementary approaches, and particularly bringing in incentives and the idea of contracts and using contracts to specify what the standards are, and then to hold the participants accountable with a financial penalty or complete loss of contract. I think the other key message here is that this collaboration is a bit messier, and there needs to be commitment to process. And so how you engage, and we heard different examples from different countries of how the different stakeholders are engaged, at what level, from the level of the NGOs to the level of across ministries and the president, that getting the right platforms and getting that process in place, and having someone facilitating with some authority to broker across the interests of the different stakeholders, and having the capacity to do that, which I don't think we have explicitly identified in these systems, that role and that function and who should play it. And finally, the will, that if you don't set up the whole culture of collaboration and commitment to that, that it's not going to just happen on its own. But that these are all I think, longer term endeavors, and none of them, we don't know any country where these are working perfectly, that the capacity to carry this out is also quite high. So just to conclude today, I hope that we got a little bit more excited about regulation than just no smoking signs with people smoking under them. That there is really an opportunity to make much better use of this control knob, I think, in all of the countries, to take a realistic view, to be honest about the current situation with regulation, be honest about it, what it can do, what it can't do, and then step back and say, what can we do differently? To have a more holistic approach, recognizing it's not just about regulating private providers, that distinction is not so important, that we're trying to create a platform for all providers to work together, maybe compete, maybe not, but to have a set of rules that they're playing by, that there is a set of rules that is based in reality, that there's some participation in creating them, that they have that social legitimacy, that they are realistic, and that there are the right balance of incentives. I think some financial incentives, of course, are powerful, but those aren't the only incentives. And creating that whole environment so that all of the pieces work together, so that everybody feels that it's more beneficial to work in that direction than not, and that they're rewarded for that, and that the system is all working towards the same objectives. Thank you very much for this engaging conversation, and we'll talk about this.
Great job. Okay, so we're going to take a 15-minute break. We'll start again at 10:15, okay? And if you haven't read the case, we're talking about the next case is counterfeit medicines in Nigeria. Take a quick look at it. Thank you very much, Cheryl.